for the opportunity to present at your conference. I really appreciate it. My topic today will be precision medicine in low-grade gliomas. This will be the outline of my talk. I'm going to start with definition of a precision medicine, and I'm going to show you a politician definition. And you can see they make it appealing like everything they do, but it's really not that simple. And I will show you what I think is really precision medicine. Now, why I like to talk about low-grade gliomas? Because they're the most common, the most diverse childhood brain tumors, and also they're the most difficult to treat if surgery is not a curative, and can be a lifelong disease, which is major for the child and the family. I showed you this slide before. This shows that low-grade gliomas are the most common childhood brain tumors. For many years, almost 20 to 30 years, we've been using chemotherapy for low-grade glioma, but it's really not a precision medicine. If you can see, none of these regimens we use as standard of care for low-grade glioma is a curative. And curative, I mean complete response. So this is really not a precision medicine. As I showed you, as I talked to you before about low-grade gliomas, it's the overall survival is easy. Most of them are alive. The problem is the event-free survival. So most of these children, if the surgery is not a curative, require multiple therapies. This is a real case of mine, and the child started within the first 3 years of life. And you can see every vertical line is a real progression. And I say real progression because a lot of times these patients have a small progression we do not treat. But this is a progression that requires the treatment. And you can see the burden of the treatment on this child and his family. And after we exhausted everything, we just continue to watch him. You can see these small progressive diseases with yellow after the age of 20. And finally, we had to go for another surgery, and he developed complications from the surgery that required aggressive physical therapy and occupational therapy, and treatment for hidradenitis suppurativa with Humira. Targeted therapy. Most of what we think of targeted therapy is what people think from media aspect, is something easy. You just give and it cure the tumor without complication. And I personally think different, and I will show you in this talk, and I hopefully can convince you that targeted therapy or precision medicine is not only chemotherapy by mouth or IV, but also can be other things. I'm a simple clinician, so for me, a cancer can happen if a proto-oncogene activated or a tumor suppressor is inactivated. And this is the main tumor suppressors or oncogenes in low-grade gliomas. I want you to pay attention to the BRAF1 and the tuberous sclerosis and the neurofibromatosis aspects. This is a paper we published about 11 years ago, and we speculated what potential therapies that can come in the future for low-grade gliomas. And you can see some of these drugs that are becoming available, like selumetinib, AZD6244, and in the tuberous sclerosis, mTOR inhibitors. And I will talk more about this. The BRAF is a main aberration in low-grade gliomas like other cancers, and it can be a point mutation or a structural aberration, which means fusion or duplication. I'll start with the point mutation, although it's not the most common in low-grade gliomas, but it's easier to start with talking about, and it's a point mutation in the hotspot V600E. And this story started in melanoma, as you know, and that's what led the anti-V600E drugs like dabrafenib or vemurafenib for melanoma, and then other cancers started being targeted for the same treatment if they have the same aberration. This was a very nice study from Germany, I think, where they screened 1,300 tumors. We knew by that time that BRAF fusion or duplication is common in low-grade gliomas, but nobody knew how common is the V600E. And this study was amazing because it showed that some of the tumors like pleomorphic xanthochromic astrocytoma or a PXA or ganglioma GG have the V600E more common than the BRAF structural aberration. Again, BRAF structural aberration is a fusion or duplication. In pilocytic astrocytoma, it was about 9%, like other studies. Now, the structural aberration of BRAF. Think of the BRAF as two domains, the RAS binding domain and the kinase domain. The kinase domain is the active one. Think of you truncate or cut the RAS binding domain, and according to how much you cut, the aberration can be different. Then take the kinase domain, the active one, and fuse it with another gene. And here you can see different possible mutations or fusions for the BRAF. Kinase domain. And then you have the most common is the KIAA1549. And then this causes a constitutive activation of the BRAF. The RAS binding domain used to be acting as a regulator for activation. But now this is gone, so this BRAF is always active, and that's what causes a tumor. And in low-grade gliomas, it causes low-grade glioma. And these are other tumors involved. This was a study we did in Nature Genetics, and we wanted to look at other low-grade gliomas. You know, low-grade gliomas grade 2 are not common in children, they are common in adults. So we wanted to look at them because most of people studied pilocytic astrocytoma, ganglioma, pleomorphic xanthochromic astrocytoma, but nobody had real discussion about grade 2 tumors. And to our surprise, we found that FGFR is significantly abnormal in grade 2 tumors. And these grade 2 tumors can be different ones. It can be oligoastrocytoma, diffuse astrocytoma, oligodendroglioma, but the whole point is that grade 2 have different FGFR aberration, and similar to the BRAF, these could be point mutation or fusion. So almost a third of these tumors had some aberration in FGFR, and this was not reported before. Interestingly, I want you to pay attention, DNET, this embryoblastic neuroepithelial tumor, was for the first time found to have some tumorigenesis behind it, and this prompted our next research project. And we took this to the next step. We looked at rare low-grade gliomas, and we wanted to compare morphology with genetics. And we were surprised to see that morphology correlates with genetics. So tumors like DNET, because they look like oligo tumors, have also FGFR aberrations. Tumors like angiocentric astrocytoma or glioma, they look like a diffuse astrocytoma, have also the same aberration. So this showed that in low-grade glioma, the MAP kinase pathway is almost always activated, and this can be by different ways. Again, going back to this graph, now we have more potential therapies for these tumors. So if you have BRAF V600E mutation, you can have vemurafenib or dabrafenib or TAC580. It's a new MEK inhibitor that can target the V600E and the BRAF fusion, and it's once a week. There are a couple of clinical trials for this drug. If you have the BRAF fusion or duplication, then MEK inhibitors like selumetinib, trametinib, and other MEK inhibitors can work on these tumors. TAC580 is one, also works on these tumors, as I said, like other drugs. Everolimus and sirolimus, if you have mTOR inhibitor, if you have tuberous sclerosis complex, they can work for on these tumors. And if you have FGFR, there are FGFR inhibitors like dovatinib and erdafitinib. However, our experience with these drugs have showed a lot of toxicity. We use them on a compassionate basis, so we hope the next generation will have less side effects. So are we there yet? So now it seems that depending on what your low-grade glioma is, you can have different treatments. If you have NF1, MEK inhibitors can work. If you have SIGA, subependymal giant cell astrocytoma, which is part of the tuberous sclerosis, mTOR inhibitors will work. If you have a sporadic low-grade glioma, then depending on what aberration you have, you will find the treatment. It could be anti-V600E, it could be MEK inhibitor, it could be anti-EGFR or anti-FGFR inhibitors. This is a real case of the V600E drugs and their impact. The response is really amazing. So from the right to left, you can see the tumor before the dabrafenib. The tumor have V600E. We use the dabrafenib, and then 8 weeks later, see the amazing response, and 16 weeks more response. Now, the problem with these drugs, they have like everything side effects, but also the cost. The cost is incredible. It's about $12,000 per month, and I don't think most of the world can afford such cost. Another problem with these drugs is that the tumor becomes dependent on this. For how long you can use it, that's the problem. I have patients who have been on it for 5 years, and whenever you try to stop it, the tumor comes back. Look at this, the same patient. So 3 years on therapy, and we had 1 week interruption. There was confusion about mailing the chemo, and the patient did not receive it. And the tumor came back fast, and the patient had clinical symptoms. However, there was no resistance. And we resumed the chemo. The patient had clinical improvement within 2 days, and the radiological improvement that we showed with the previous slide came back. So again, we were able to salvage, but as I said, this patient has been in it for 5 years, and that's $12,000 per month. Now, targeted therapy, as I said, they are not benign, and this is some of the complications. I mentioned some of the issues, but side effects are serious. Patients can have cardiac toxicity, ocular toxicity, and some skeletal issues, but musculoskeletal, but also there could be side effects we're not aware of as we're learning about these drugs because they are new. So they are not the cure for everything. Another part of precision medicine I like to talk, and I talked about that in my delayed diagnosis project, is I think this is really more important in low-grade glioma. If we can do a good job for our neurosurgeon and diagnose these tumors early, we can help them resect the tumor or at least save life and functionality. And these are some of the papers we have on delayed diagnosis, and I'm happy to discuss by email any issues about these topics for the sake of time. Another example of early diagnosis, I mentioned that in my previous talk, so I will not talk about it, but you can see the difference between a parent who diagnosed and physicians who diagnosed. And you can see that the parent practiced precision medicine here more than the physician. I mentioned these examples in the other talk, the same thing, precision medicine in this case, because the tumor was resected. In these tumors, no neurosurgeon can resect such a tumor, so we lost the window. Accurate diagnosis is really very important aspect of a precision medicine. We don't talk about it enough because for us oncologists, if we don't get accurate diagnosis by the pathologist and the radiologist, then we cannot give proper treatment. And that's very important. And this can save the patient from a lot of toxicity. One of the famous lessons is the Children Cancer Group Study for High-Grade Glioma, CCG 945, where we learned that many patients received chemotherapy as high-grade glioma that did not receive it. This is the study I'm talking about. They found that on further central pathology review that 70 patients were really low-grade glioma but were diagnosed as high-grade glioma because the pathologist was not experienced in low-grade glioma in children. And sometimes these patients can be difficult to diagnose. So that's another precision medicine, in my opinion, that we need to talk about more than just fancy targeted therapy. This is a real case I have a few years ago, and the patient was referred to us as high-grade glioma, and in fact, they almost started chemotherapy. They didn't give radiation because she was only 9 months old. We reviewed the case here, and our pathologist said this is pilocytic astrocytoma, and his explanation was that sometimes the background of the normal tissue may mislead the pathologist and cause the diagnosis of high-grade tumor. The patient was only observed after good surgery by our neurosurgeon and no relapse, and the child is functioning normally. This is precision medicine and much cheaper than other therapies that takes 12 months, 12,000 year per month, $12,000 per month. Sometimes do no harm is the old principle, and sometimes it's the most important in precision medicine, and we forget it sometimes. It's very important in low-grade gliomas, especially optic pathway glioma, for example, in F1 and tictile tumors. I've seen many cases where the patient had surgery that they did not need, and the patient has major complications. You can treat optic pathway glioma in F1 without surgery and save the patient from unnecessary surgery. And sometimes you can just observe them. You don't need to treat. You just have to be patient with them. And this is a real case of mine. The patient had this tumor at the age of 9 months. And and I pushed the mother to give chemotherapy. I pressured her a lot, and she kept refusing. And we continued to observe against my desire, and the tumor shrunk a little after 36 months. So the mother did better job than me. And it was really hard decision for me, because not doing anything is the toughest decision, but sometimes do no harm is the best thing. And that's why I always emphasize about the final part of precision medicine in low-grade glioma or anything. Multidisciplinary, in my opinion, is the most important precision medicine. And I think every child with brain tumor or any cancer should be discussed as a team that includes everybody. This is a slide I like to use from my mentor, Eric Buffet, and I use it a lot, and he uses it, but this is precision medicine. You cannot have more precision medicine than this, where everybody zoom on this target, which is the patient here. This is the ultimate precision medicine, and I think we should invest in this before anything else. Sometimes I get emails, we are going to start service, what MRI machine we should buy, what intra-op navigator we should buy, and I always say start with the team, invest in the team, and then with the basic, and then you grow from there. So for me, MDC is the most important precision medicine in all in low-grade gliomas management. So for me, the definition of precision medicine low-grade glioma is MDC, early diagnosis, and this can be achieved by better education for our medical students, nurses, and residents, better accurate diagnosis, do no harm, and targeted therapy, of course. I'm not denying the importance of targeted therapy, but I think it should come after we have all the other things in line. If you are not part of the Cure for Kids, please join it. It's an amazing resource for your residents and medical students. It has many resources other than oncology. Please feel free to email me. I have these talks on Cure for Kids for anyone who is interested. Thank you.